Once again, good morning. My name is Leanne Foster, and I am a provider outreach and education specialist here at WPS. And today we welcome to our session on evaluation and management, choosing your level of service. I want to thank everyone for attending today's session. I do have just a couple of housekeeping things that I have to go through before we start with our material for today. First is going to be the training material. Material is available on our live events page for your convenience. A link is being placed in the chat for you. Once you access that link, you're in our live events page. You're going to look for today's event, which should be at the top, and you're going to click on the event materials link. That's going to open up the presentation for today's session. We will be leveraging chat for any questions that you have today. If there are more questions than time allows, we will be sending out a follow-up document to the attendees of this session. Certainly feel free to ask your questions and pop those into the chat. Like I said, I will be checking in with Ashley. I don't feel that you have to wait until we get to that question and answer portion. I don't want anyone to forget their questions that they have, so feel free to throw those in there. Also, your input is extraordinarily important to us. It drives everything that we do, and we want there to be a dialogue or a feedback loop between you, the provider community, and us as the MAC. We do have to leverage chat for that. However, you will also have an opportunity to provide that through a survey that you'll be asked to take towards the end of this session. Again, I encourage you and thank you ahead of time for your time in completing that. That lets us know what we're doing well, what we could do to support you better as you move through the Medicare program. It's also something that we look at to see if there are other educational topics that you would like to see us offer. So that's not a survey that no one looks at. We do truly look at that, and we do use that information to improve. This is our disclaimer. So this information is accurate as of today. If you've worked with the Medicare program for any period of time, you're aware that Medicare changes and tends to change often. So I'll encourage you to continue to monitor official CMS communications. That includes our website, just to make sure that you are following current rules and regulations for the Medicare program. Also, CMS does prohibit the photographing, screenshotting, or recording of the session for profit-making purposes. We simply don't know what you're going to do with that, and CMS just wants to make sure that the MACs are in charge of those recordings. And as I mentioned, I am recording this session, and it will be available on our Encore presentation page for 60 to 90 days past this webinar without the need to access our YouTube channel. We understand that not necessarily everyone can go to YouTube during work hours or on their work computers. After the 60 to 90 days, it will remain on our YouTube channel, and a link has been provided for you in the chat. It will be available until the material, as long as the material is still relevant and accurate. If something changes, if the material is no longer accurate, we will take that down, but otherwise that will be available to you so that if you need to see something again, have questions, or if you know somebody might find this information or this presentation helpful, you can certainly feel free to share that with them. Last thing before we get to our agenda, as with most every facet of our lives, acronyms are a part of it. Lots of acronyms are used throughout our daily lives. So what I have done, today's not going to be an exception. There are going to be some acronyms used today, and I've simply included a list here for those that I'll be using today. Also, there's an acronym list available on our website if you need, if I'm using anything that you need. So that brings me to our agenda for today. In this session, as I said earlier, this session is about evaluation and management specific to choosing your level of service. Evaluation and management is a huge part of Medicare billing. It represents approximately 40% of all claims that are billed to the Medicare program. So today we are going to focus on that choosing of the level of service. There's a lot of facets to evaluation and management services. So we do offer a lot of education regarding specific services, specific billing requirements. So If there's something more that you're looking for with relationship to evaluation and management, I do encourage you to check out those encore presentations, because we do actually have a playlist on our YouTube channel devoted to evaluation and management services. But as I said, today we are going to strive to provide an understanding of how to select the appropriate level of service when you're reporting those evaluation and management codes. So we're going to include a brief overview of what you're looking for. We're going to talk about the elements of the medical decision making. We're also going to define those level of service, and we are going to include some information about time. And then I'm going to provide a brief overview of some of the key points of documentation that we're looking for. So the first determinant of coverage in the Medicare program, and that includes evaluation and management services, is whether or not the service is medically necessary for the patient's problem, condition that they're being seen for. So per the Social Security Act of 1935, Section 1862, the services must be reasonable and necessary to treat the illness or injury or to improve the functioning of a malformed body member. So this is all based on your documentation. The things that MACs are looking for when they look at that documentation, they're looking to see, what are you doing for the patient? Why does the patient need your service for this encounter? Was it reasonable? Was it medically necessary? And we're also looking to make sure that it's not statutorily excluded. These are what they look for first and foremost. And again, you'll hear me say this a lot today. It all comes down to documentation. The documentation must support that level of service. And you'll hear me say this as well. It needs to show the provider's proof of thought, and MACs will ask themselves if the documentation versus what is billed makes sense. So I just want to call out some changes. They were made a few years ago, but we still get questions. So I just want to make sure I'm calling out that the AMA does own the description of the procedure codes, and they've made some changes to those. They make changes to them annually, but some of the biggest changes were made in January of 2021 for office and other outpatient services. And then the other categories of services had significant changes to them in January of 2023. Parts of those changes included the level of service and how it's chosen. So there's a couple of things that go into this, and you can either choose your level of service based on time. So what time was spent during that encounter? And we'll talk more about that in a few minutes. Or medical decision making. You can choose in most cases. There are some exceptions. Emergency department and critical care services do have to be based off of time. But for other services, you're going to be able to choose, again, time or medical decision making. And you want to select the one that's most advantageous to you. You don't want to, you did the work. Don't leave money on the table. So you'll want to look at which one makes the most sense for that encounter and for the services that were provided. Before I get into the levels of service, I do also want to talk about new versus established patient. This is a question that we see, and this is also a fairly common denial reason where we see multiple E&M visits on the same day, and we have I shouldn't say just multiple E&M visits, but we're getting multiple new patient visits on the same day. So it seems to be that there's sometimes some confusion on what constitutes a new versus an established patient. So CMS and the CPT define new versus established being a new patient is a patient that is new to that provider. So basically you want to ask yourself, has the patient received services from that provider, that physician or practitioner, or the same group, or of a provider of the same specialty in the last 3 years? And a question that we get is, if I have a provider in my group and the patient saw them in the last 3 years, but they've now moved over to another group, they're with a new group, but they've seen that patient in the last 3 years. That's still an established patient. So these are the three questions you want to ask yourself. And the screenshot that you're seeing here is actually a decision tree diagram that is included in the CPT. And this is super helpful when trying to determine whether or not you have a new or an established patient. So when you're choosing your level of service, the majority of time as I said, you're going to be choosing between time and medical decision making, except for those items that I called out as an exception, which are the emergency room visits and the critical care time. Most categories for E&M services have 4 levels, though when you're looking at the codes, you're going to find that some only have 3 because they've combined the low and the straightforward levels. So you're going to be looking at choosing between straightforward, low, moderate, or high. And when you're doing this, you do have to make sure that you meet or exceed 2 of the 3 elements. So for example, if you have a low problem, you have a moderate level of data that was reviewed and analyzed, and we'll talk about that a little bit more in a few minutes, and you have a moderate risk level of risk, you'll choose moderate for your level of service. If it were reverse and you had uh, maybe you had a low problem and you had a moderate level of data, but you had low risk, that's still going to qualify as low. So again, 2 out of the 3 in order to select that level of service. And again, that documentation, like I said, you're going to hear this from me a lot today. The documentation is going to need to support that and include enough information so that that level of service is clear. And the practitioners, the providers need to make sure that they are including enough documentation. We're not asking for them to write a book or a novel, but it does need to be enough information that the level of service is clear and the time is clear. So before I get to medical decision making, I'm going to spend some time on choosing your level based off of time. So the times identified in the code descriptor, it'll say you must meet X amount of minutes. That can vary per code. The lowest level is 15 minutes and it goes up from there. But you must meet that number of minutes in order to choose that level of service. And when you're using time, it is the time that is spent on that same calendar date. This can include both face-to-face and non-face-to-face time. So your practitioners, your providers, they want to make sure that they're documenting both that face-to-face and non-face-to-face time so that they can account for the work for that patient. So again, they're not leaving money on the table. You did the work. We want to make sure that you bill for that. And sometimes that non-face-to-face time can make the difference in the level of service. It may only be a few minutes, but it can change that level of service. So when the time is being documented, this is one that we get a question a lot. The provider does need to document a specific amount of time. What I mean by that is not a range. They don't need to stopwatch themselves. We're not looking for that, but they do need to say, I spent 30 minutes. You want to stay away from statements like, I spent approximately 30 minutes. It's not a best practice. You also don't want to say, I spent more than 30 minutes. Well, how much time did they spend? Because if they spent 45, depending on the service, that could actually be a higher level of code, but the documentation calls out 30 minutes. The other thing you want to stay away from, it's not a best practice, is a range. I spent 30 to 60 minutes. Again, it could make a difference in that level of service. So you want to be specific on the amount of time. Again, not expecting a stopwatch, but a specific time does need to be documented. And we'll talk about this a little bit more when we get to documentation, but it has to make sense. And in your resources section today, I've also included some information about how CMS expects the MACs to review documentation for the accuracy of time. And that link is going to take you to the Medicare Claims Processing Manual, and it's going to be Chapter 12, Section 30.6 6.7, and it just lays that out if you'd like to look a little deeper into that. So face-to-face time that you should count, it includes a lot of different things. It can include preparing to see the patients. Maybe this is when you're reviewing previous notes just to get ready to see the patient in that encounter. It can be time spent obtaining or reviewing separately obtained histories. So maybe there's a conversation with a family member or an independent historian. It can be the time performing the exam. That's obviously going to likely be face-to-face time, but that is time that should be counted. It could be non-face-to-face time that's spent on counseling or educating the patient, family member, a caregiver. That counts as time that you spent on that patient in that encounter. You want to include ordering any medications or tests or procedures. But the key here is that if you're counting that time, it would need to have been done by that practitioner. Okay. And you also want to make sure that, particularly with some of the tests and the procedures, it's not something that's being separately billed. So you don't want to count time if that procedure or that service is going to be separately billed. You don't want to double dip there. You'll also want to make sure that you're accounting for time spent on setting up referrals and communicating with other healthcare providers. Again, not separately reported is going to come up a lot here, but if you're setting those up, those conversations may not happen in front of the beneficiary, but it is related to that encounter, so you should count that. Also documenting the encounter. So after the encounter, if they're doing the documentation for that, that should be counted. However, again, it is in the instance when the practitioner is entering that information themselves. You also want to count any time they are doing an independent interpretation of results and communicating that information, those results. Now, here again, you're going to see that it's something that's not separately reported. So if they're ordering for a technical component of an imaging service, but that professional component is going to be performed elsewhere, you're not going to be counting that as an independent interpretation at that point. And then also care coordination. So are they needing to coordinate service with other practitioners, or maybe they're engaging a community agency to coordinate care when they leave it or get services that they need based on what occurred in that encounter. Things not to count. There are some things that you want to make sure you're not attributing time in that encounter. Uh, as I've said a few times, performance of any services that are separately reported. If they're separately reported, they're being billed to Medicare. The time that it took to perform those services is already accounted for in a different service. So it's not going to be counted for in this particular E&M service. It's double dipping, and we don't want to do that. Travel time to the encounter, that is not something that is going to be counted. And then also teaching that's general and not specific to the management of that individual patient's care. You want to make sure that you're not counting that time. Uh, the other thing that I want to mention here is if you're having, your practitioners are having conversations with the patient, more of a kind of just getting to know each other, just general conversation. Let's say maybe both of you have a hobby in mind or a book, or you're talking about one of the things that we will see, those of us that work at the MACs, if our providers know that we work for Medicare, sometimes they'll ask questions about things that are happening in the Medicare space. Those are not related to your encounter. They're not related to the treatment and management of that individual patient, and they should not be counted. So before I get into the individual elements, I do want to just cover the overview of these elements. So the elements of MDM include three things. We're looking at three things, and the parts include the problem, and this is going to be the number and complexity of the problem or problems that are addressed in the encounter. We'll talk about problem a little bit more, but the key thing there for the verbiage is in the encounter. We often see patients that have a long list of problems. They may have hypertension, diabetes, high cholesterol, but not necessarily all of those are going to be addressed in every single encounter. So we need to know what problems are being addressed. It also comes down to the complexity of those problems, and we'll talk about that a little bit more in a few minutes. The next element is going to be the amount and complexity of the data that's to be reviewed and analyzed. And it's reviewed and analyzed in creating that plan of care. The third piece we're going to look at is going to be the risk. So what are the risks of complication, morbidity, or mortality from the medical decisions that are being made in that encounter? And I want to call out as we go through this, this is going to be unique to the individual patient. I'll give some examples throughout the day where a problem may not be of a particularly high risk for one patient. I'll use colds just as an example at the moment. A patient goes in for a cold, they're otherwise very healthy. A cold's not a really large problem, not a high risk. However, if you have a patient that goes in with severe CPOD, a cold is a much more serious problem. And so it may be the same diagnosis, but the risk it's all based on the individual patient. So none of this is determined purely, particularly with risk, purely by diagnosis. Sorry, my slide didn't shift there. So we'll start with problem. So the AMA defines a problem as a disease, a condition, an illness, an injury, a symptom, a sign, a finding, a complaint, or some other matter that's addressed in the encounter. One of the questions that we received was about a differential versus a final diagnosis. We're looking at what is happening in the encounter. And it's very possible that during the encounter, you don't have a final diagnosis. And it may be that the patient is complaining of a rash and you need to order more testing. The rash would be the item that was addressed in that encounter. So again, it doesn't necessarily need to be a disease. It can be that symptom. So as I've stated a couple of times, it does have to be a problem that is addressed in the encounter. So kind of going back, building on my examples, you have a patient who is coming to you today for a rash on the elbow. They also have diabetes, hypertension, and high cholesterol. The documentation has to show what was addressed in that encounter today, and they're addressing the rash. They would be looking at that problem, unless perhaps they're looking at the diabetes because the diabetes could impact their ability to heal from that rash. In that instance, perhaps it's the rash and the diabetes, but not necessarily the hypertension or the high cholesterol. Again, you have to look at what's addressed in that encounter. It's not every diagnosis or every condition that patient has every time they come in. It's going to be specific to that snapshot in time and that patient. And as I said, that patient, so we're looking at the complexity for that specific patient. I use that cold example. Somebody who's relatively healthy, cold's not a big deal. Somebody that has CPOD or severe breathing problems in some way, that cold's going to be a much bigger deal. Now, as we go through problem, we are going to talk about the levels for MDM, and the levels are going to be straightforward, low, moderate, and high. So starting with a self-limited or minor problem. This is something that's has a definite and prescribed course. Maybe it's transient in nature and it's not something that is likely to alter the patient's healthcare or healthcare status. That's what we mean by self-limited or a minor problem. And I keep coming back to the same example, but these are things that typically fall into that category. Things like a cold, a sinus infection, or a rash. But as I've stated before, it depends on the patient. The documentation is going to need to support that. Your practitioner is going to make that decision about the severity of the problem for the patient, and it needs to be clearly stated in that documentation. So for a low problem, there's a few things that fall into this category. Two or more self-limited problems. So what we just discussed, say they had a rash and a cold, that would be something that then would bump up to a low problem. If you have a stable chronic condition, so an example here would be diabetes is a condition, it's at goal, it's stable. They've had their glucose and their A1Cs at the appropriate levels for a period of time, and they are at the goal that is set for the doctor. Now, those goals are again going to be set by that practitioner, defining whether or not this is a stable condition is uh, up to that practitioner, that provider. And chronic is a question that we often get. Now, the definition of chronic that Medicare is looking at is typically it's something that is going to last or has lasted for 12 months or until the end of the patient's life. So again, you're going to be looking to the documentation to identify whether or not that is chronic. It is not solely based off of a diagnosis. Acute uncomplicated. This is going to be another example where you may have a cold, but the over-counter medication is not helping. So maybe they're coming to the provider to consider steroids or other medications to help clear that up. Same thing with a rash. They have poison ivy, but it's not resolving itself with anything they've tried at home, and maybe they need to have additional testing to see. So that's what we're looking for there. A stable acute illness, this could be something where a patient, say, has a sinus infection and the practitioner has started the treatment, they've had it a while, and it's unresolved. So the patient or it's unresolved, but they are improving. So it is expected to run its course, and they're responding as the goals were set. The other thing you'll see here is an acute uncomplicated illness or injury that might require a higher level of care. So this is something that's going to be a recent or new problem, and it has maybe a low risk of complications, morbidity, mortality, but it does require treatment. Maybe they need some observation care. Maybe the practitioner has decided that they need to be admitted as an inpatient. But again, that practitioner is going to categorize that level of problem. Next, we get into a moderate level of problem. So here we're looking at one or more chronic illnesses with exacerbation. What that means is it could be, I'm going to use diabetes here, that could be diabetes and they're not at goal. You've maybe set glucose and A1C levels and they are just not getting there, or it's getting worse. That is something that would be one or more chronic with exacerbation. If they have two or more stable chronic conditions, that would be a moderate problem. If they have one undiagnosed new problem, remember I talked about the problem is not just a diagnosis, it could be a condition or a symptom. So they're coming in for low back pain, or maybe they're coming in for abdominal pain. We don't know the reason yet. We just know that that abdominal pain or that back pain is there, and they're ordering more testing. That abdominal or back pain, or if they have both, that is the problem for that day. Now, in a later encounter, there might be a diagnosis, but again, that will be used for that next encounter, if there's a next encounter. Next is going to be an acute illness with systemic symptoms. Sorry, can't say that word today, apparently. So one acute with systemic symptoms. This is going to include things where they have an issue, but they have systemic systems impacting respiratory system, cardiovascular system, their musculoskeletal system. It's something that you can identify that it's impacting a system of the body. And then the last one here is going to be acute complicated. And this is going to be something that's maybe requiring treatment and evaluation of an entire body system. Maybe there's multiple treatment options. Maybe the injury is fairly extensive. So for an example would be, say, a patient presents with a laceration to the scalp. Based on the information from the patient, the practitioner is also performing a neurological exam. The patient's unconscious and struggling to breathe on their own. Patient is presenting for follow-up to a fall that they experienced some additional problems with their balance or gait. Again, it's going to be unique to the patient, so you want to look to see what is happening. So next we're looking at a high problem. So if you're not sure if the exacerbation is severe or not and meets the level of high, and we run into this question a lot, it has to be clear in the documentation. There may be instances where you have to go back to the provider and ask questions, but you can't lead them in a direction of a level. So you want to be careful with that. And when we're looking at high, we're looking at one or more chronic with severe exacerbation. And like I said, that documentation has to support. So for an example, maybe the blood sugar on a diabetic has shot up to 300 and it's sudden and we don't know why. Or maybe you have someone that has CPOD and it's wildfire season and the smoke from those fires is causing uh, severe breathing issues until that smoke dissipates. That would be kind of an example of a severe exacerbation. Next is going to be one acute or chronic illness that is a threat to life or bodily function. Again, that documentation is going to support. One example would be that you have a patient that's coming in for a UTI and maybe it's leading into sepsis. That would be something that is going to be a severe exacerbation. Next element we want to talk about is going to be data. And this is going to be the data that is analyzed in the process of determining the medical management and plan of care for that patient. It all goes back to proof of thought and it needs to be documented and that documentation needs to support. So as I said, it is data that is analyzed and it's used during the medical decision making to determine that plan of care. What are the next steps? It can go into diagnosing that patient. Now, when we talk about data, we are talking about very similar levels. We're looking at straightforward, limited, moderate, and high. The CPT does have a chart that does actually go through these levels and what's included, but we're going to talk about them. Now, each level is going to have categories, and these categories are going to be based on that level of care. Here, I'm showing you a screenshot so you can see the difference. I'm using the limited and moderate to show you how those categories change. As you see here, limited has 2 categories, moderate has 3, and each category is going to show an increasing level of review and an increasing level of analysis. And it'll tell you how many items that you have to meet, what the requirements are for each. So for instance, looking at the screenshot of limited, it is saying that it's any combination of 2 from the following bullets. So it doesn't have to be the same 2. It could be that you have a review of an external note and the result from a unique test. It could be that you have 2 unique tests, but you have to meet 2 from that category in order to meet that level. So before we get into the levels, I do want to talk about a couple of things that we often see questions on. And one of them is defining a test. And a test is going to be imaging, and this includes independent interpretation. So X-rays, MRIs, things of that nature. We're looking at laboratory tests, so labs, psychometric or physiologic data. With the physiologic data, think those questionnaires where maybe you have to shade in body parts, rate pain. If that physiologic data is used to determine the plan of care, it does count as a test. However, with all of these, you've got to ensure that it's not separately billed. So if for imaging, if you have a chest x-ray and the technical and the professional component are going to be billed by a different provider, then that's not something that would count as an independent interpretation unless they are doing truly a separate independent interpretation in addition. So again, not separately billable. The other thing that I want to call out, the AMA does not consider pulse oximetry as a test. So the definition of unique, we get this question a lot too. Uh, with unique, you have to look at the tests that are ordered. So when you order a test, the review of that test is considered to be part of your order. Both the AMA and Medicare consider ordering it and reviewing as one item. Why would you order a test if you're not going to review it? If you ordered a test and you didn't review it, that does call into question what was the medical necessity for that particular test. So the other thing that comes into play is if you have a test that's overlapping. So if you order a lab and you also order a panel, and that particular lab that you ordered as a standalone is part of that panel, it's by CPT code. So that lab counts once, not twice. It was maybe ordered as a standalone, maybe it's something that had to be rechecked. It was also part of the initial panel. It's not two tests if it's the same procedure code. So we do look at that. One question that we do get is what happens if we order a series of a test over the next 6 months. So an example would be you're seeing the patient and you order a monthly INR test. The date of the encounter, when you order that INR test, you're going to count that for that encounter. The monthly INR is going to be one unique test, but when you see the patient again in 6 months, you can now count the review of the additional INR tests. It's not a unique test, but again, you're looking at those results and you're using them to determine that plan of care. The next part of unique is unique source. So when we talk unique source, we are talking about a different physician or practitioner. We're looking for a distinct group or a different group, a different specialty or subspecialty, or a unique entity. And this is not going to include review of your previous tests. It's not a different provider. It's not a review of other medical records from physicians in the same group with the same specialty. That's not going to count as unique. But an example of unique would be is if you're looking at the records from, say they had a couple of ER visits before you came, that ER visits were at ABC Hospital and you're at XYZ Medical Group, those ER visit records are going to count. Also, if they were running tests from those ER visits, reviewing those tests would count because they're tests, they're a unique item. If they're unique tests, they would count, but also they're coming from a unique source. External, some aspects of unique are included here, but external is basically saying that you're not reviewing your own previous notes. They're coming from outside of your clinic or a member of your group with a different specialty or subspecialty. Now for Medicare, we're looking at that specialty. So external records are going to include their medical records, communications, could be test results from that external physician or qualified practitioner, that other facility or healthcare organization. One thing I do want to point out as an external physician or other healthcare professional is external if they're not in the same practice, don't have the same specialty, and you're also looking at you're not sharing that medical record system. One question that we get is, I have a nurse practitioner who ordered the test, and then the MD or DO sees the patient and reviews those test results, they do ask if they can count. Now, in this case, they can be counted because that nurse practitioner and that physician are not the same specialty. They're in the same group, but they're not in the same specialty. Next, I want to talk about discussion. So this is something we get asked about a lot, and what is a discussion? What counts as a discussion? So the discussion is defined as a real-time discussion between practitioners about that patient's care. It's an interactive exchange. It may be face-to-face, but it also may be asynchronous. It may be through a chat. It may be through a text. It may be through an email. It does have to happen, though, in a short period of time. You're going to want that to have started the day of the encounter, within a couple of days. CMS does not define, but it's usually within a few days of each other that it started. And it has to be direct. It has to be with an appropriate source, so that other healthcare practitioner. It could be a conversation where the practitioner who is seeing the patient wants to have a conversation with the radiologist who read the x-ray to discuss the results, because maybe they have questions. Documentation has to show that exchange, and I want to call out that that exchange can't happen just through the medical records. So again, it's got to be interactive, chat, email, phone, face-to-face, and it's not necessarily going to happen in front of that patient. So data for straightforward. Now with straightforward data, we're really looking at minimal or no data. So there were no tests, there were no tests ordered, no tests reviewed. So straightforward, just not a lot of data or no data at all. For low, you do need to meet the requirements of at least one or two of the categories. So this is going to include tests and documents, but you'd have to have two. It could also include that assessment requiring an independent historian. And I've also included a link to a resource here that has some Q&As from the AMA about data, which you may find helpful as well. One question that we do get often as well is regarding that independent historian. That does need to be documented. One, that there was an independent historian, but also the reason an independent historian is needed. And it has to be because the patient cannot provide a complete or reliable history. It's not the same thing as, say, a spouse or a child or a family member adding information during the encounter. This is going to be something that's utilized when, again, the patient in the encounter is unable to give a reliable history. So for moderate data, they have to meet one of the three categories in the CPT chart. This includes your tests, your documents. You're also going to notice that independent historian has been moved up a little bit. It's been moved up into that second category. And you're also going to see independent interpretation of tests when they're not billed separately, and they do need to document that. So an independent interpretation is not going to be, is not going to be, I've reviewed the radiologist's results and I agree. This is going to be documentation that, while not on the same level as what a radiologist might do, it does have to show their interpretation and their findings, and then how they're being used in that medical management. One thing I do want to also point out is that discussion of management or interpretation, and that comes back to that discussion defined. Again, it's not just in those medical records, it's going to be that interactive conversation. So data, as you can, with data, you're going to want to meet 2 out of the 3. So again, this includes tests. It would require the 3 tests there, independent interpretation of a test, or discussion of management or test interpretation. So those are the items that we're looking for there, but you do need to meet 2 out of the 3. It's not 2 out of the 3 bullets with any of these. It's 2 items of the bulleted items listed in the categories. Next, we're going to talk about risk. And risk is the one that sometimes people do struggle with. And again, with all of this, and particularly risk, it is absolutely going to be unique to the patient. So here we're talking about the risk of complications and morbidity or mortality to the patient based on the plan of care or the management decisions that are being made. What are the tests? What's the risk to the patient of the tests? What's the risk to the patient of any diagnostic procedures? It could be the risk to a patient for prescribing a prescription. Now, prescription management is something that you'll hear me talk about here a little bit. We get that question all the time. They give examples in the CPT book for risk. This is all going to be unique to the patient. So for instance, going back to the cold, for a relatively healthy person, that cold is low risk. For somebody with CPOD, that's a pretty high risk situation. Prescription management. What is the risk to the patient for prescribing that prescription to that patient? It's not an automatic. It's not, if you're renewing a prescription that the patient's been on and they're tolerating it well, there may be relatively low risk to that patient. If it's a new medication or it has some type of interaction, that is something that could be high risk. Chemotherapy is one that comes into play as well. We'll talk about that a little bit later with toxicity levels. But again, it may or may not be high risk to the patient in that encounter. So things to consider. They are going to be based on the problems addressed in that encounter. And again, different for each patient. So straightforward, I mentioned the cold. The cold diagnosis, that is an example of something that is probably likely going to be a minimal risk or maybe no risk at all. Again, they're being seen for that cold today. If you have somebody with CPOD, that's going to be a higher risk. So again, unique to the patient, and it's going to be up to the practitioner to document what they deem the risk level for that patient. It is not based off of diagnosis. Oops, sorry, 2 clicks. The low risk is going to be, again, what is the level of risk for the testing and the diagnostic procedures that are being performed? Documented by that practitioner. It's not something, again, that is based off of diagnosis. And I know you hear me say that a lot, but that is because it is truly about what is the patient being seen for and what is the risk of those decisions. Now, for moderate risks, we have some different examples here. And with moderate risk, you have to meet at least one of the 3 categories. And that category 1 still includes review of notes, ordering and reviewing tests, but it also now want to start looking at maybe there's a decision for a minor surgery. I mentioned prescription drug management. Those are things that you want to make sure that you're not just automatically deeming it moderate risk because there is a prescription. And I've included a link that provides more information. It has some Q&As about that prescription drug management. But again, are you renewing a prescription that they've been tolerating well, they haven't had any counterindications with it, there's relatively low risk? Or are you putting them on something new? It is not blanket guidance. That is something that you do need to make sure that you're looking at. High risk, this is where we get into the intensive toxicity monitoring, and I mentioned chemotherapy. Now, this is like anything else. What is the risk of the chemotherapy to the patient? Are they tolerating it well, or are they having some exacerbations from it? That is something that practitioner does have to document. And when you're looking at that toxicity monitoring, you are measuring the toxicity, not the efficacy of it. So you want to make sure that You're keeping that in mind when you're looking at that. And again, it has to be documented. And if it's unclear, you may have to go back to that practitioner. High risk also includes the decision for a major surgery, whether it is emergency or an elective surgery, and the decision for hospitalization, along with if they need escalation of their hospital care. So those are examples of what would be considered high risk. So I want to wrap up here and start talk a little bit about documentation. We get a lot of questions about what we're looking for, and it's not necessarily specific wording that we're looking for. We see a lot of questions where there's pre-populated verbiage that providers are using in their documentation. That's not necessarily wrong, but the documentation does have to be clear. It does have to document the time accurately. It does have to document the problem data and the problem that they're addressing in the encounter, the data that they were analyzing to make their medical decisions, and then what is that risk to the patient. So it has to show the medical necessity of the service. Why were these services necessary to treat the patient's problem for that encounter? So it needs to show that. It has to show that proof of thought. I do talk about that quite a bit, but it's telling us why. And when we review it, as I said earlier, the reviewers are going to be looking at whether or not, whether it's time or medical decision making, does it make sense? Uh, the elements it needs to include that evaluation and exam. It has to include the history. It has to show the assessment. It has to show the care plan. What are we doing to treat the patient? What are we doing moving forward? What's their status? And then it also has to show the services that were provided. If it's not documented, it didn't happen. Again, we're not looking for them to write a novel, but it does need to include everything. As I stated, it has to be an accurate reflection of time. As a reminder, we're not looking for them to stopwatch, but we're not looking for approximately 30 minutes. We're not looking for a range, but they do need to make sure that they are reflecting the time spent on that encounter, and it has to make sense. So it's that proof of thought. And then when we review, they're looking at those activities that are documented, and they're looking at the patient's needs versus the time spent. So if someone comes in for a cold, and I'm going to go to the extreme here, the time documented is 2 hours. That's something that might cause a reviewer to ask questions. Does it make sense? So before I check in, unfortunately, I don't know that we're going to get to questions today, but we will certainly go ahead and make sure that we grab all of those questions out of the chat. I was afraid we'd run just a little bit long today. My apologies for that, but we will get answers to all of your questions in the chat. Those of you that submitted pre-submitted questions, we did include information on those in our material today. So hopefully you were able to get answers to those questions. If not, we have a plan for that as well. Uh, Here, I do want to point out some resources that I've included. As I mentioned, we included the Chapter 12 reference, which is that Medicare Claims Processing Manual. We've also included a link to the Evaluation and Management Services Guide, which has a lot of good information. It includes some information on prolonged codes. We didn't talk about those today, but I know there were some questions on that. And then also a link that is specific to documentation for evaluation and management services that are currently under a review. So those are resources that are available to you. Like I said, unfortunately, want to be respectful of everyone's time, and we are running out of time for taking questions in the chat. However, as I said, we will be answering those, and we'll send those out in a follow-up document. If you think of questions outside of this session that you did not put into the chat, I am taking those follow-up questions for the next 7 days. And Ashley's going to be putting a link to our education mailbox in the chat. We will ask that you throw today's topic in there, which is choosing your level of service. That will let the people that are monitoring that mailbox know that they need to get those questions to me. The other thing is if you click on this link, if you've downloaded the materials, click on that link, it is going to open that email and it is going to pre-populate that subject line just to make that a little bit easier. If you do have questions that are specific to a claim that's in process, those are claim specific questions. Those do still need to go to customer service. They have access to the claims processing systems and they'll be able to advise you a little bit more directly on that claim. As I mentioned earlier, your input is incredibly valuable to us. I want to make sure that you have that opportunity to provide that feedback. So tell us what we did well, what we could have done better, and certainly what education you'd like to see us offer in the future. We do look at that, as I said, and it helps us improve our education. What we do cannot be done and done well without your input. Now, there's going to be a couple of ways that you're going to be able to provide us with your input, and one of them is going to be through the link that Ashley has just placed in the chat. Also, you're going to get a redirect after you leave the session today, and it's not spam, it's not taking you somewhere that you shouldn't go. You do want to, it's just telling you that you're leaving our webinar software and that you are going into the Qualtrics survey software. One other thing I do want to uh, check on, and sorry, I do not have the slide here. If you are attending today for continuing education credits, you're going to get an email in a couple of minutes that is going to thank you for attending, and don't delete that without looking at it. It's going to have your contact hours and the name of today's event. That can be submitted to your accreditation body or your certification body to count towards continuing education units for those certifications. If you didn't get it, one of two what things happened. It went to your junk mail or you attended by phone. If you attended by phone, I simply don't have a way to electronically confirm your attendance. In either case, send an email out to that education mailbox. Tell me that you need a certificate, and if you attended by phone, let me know what phone number you attended by. Once I confirm that attendance, I can get a certificate out to you. That will end our session for today. I want to thank you all for attending and for your patience. Again, we'll get those follow-up questions out to you. On behalf of myself, Ashley, and everyone on the WPS Provider Outreach and Education team, I'd like to thank you very much for taking the time to attend today. We know everybody's busy, so sometimes carving out this hour of time can be a bit of a challenge, so I appreciate your time in attending today. I hope you found this session helpful and that you have a great weekend. You may now disconnect.